Ladies and gentlemen, friends and colleagues, welcome to the view of the Thoraxcenter for Radcliffe Cardiology. We're doing today the wrap-up of TCT 2022 that happened in Boston last week. I'm Nicolas from Mieghem. As always, I do the wrap-up together with my good friend and colleague Joost Daemen. And Joost, it was quite an interesting TCT this year.
It was a good meeting. I think almost 7,000 participants, well represented by international faculty, attendees, fellows, industry. I think all in all a good meeting. Back after COVID, after last year's extra slim edition, I think this year was good. I have to say I enjoyed it.
A little bit jet lagged, but let's go for the first trials. And I think the main trial of the meeting, I dare to say, is the protected TAVR. There was a lot of fuss about that study and about the outcomes of the study, because it turned out to be a negative trial. In protected TAVR, 3,000 patients were one-to-one randomized to TAVI using cerebral embolic protection versus TAVI without cerebral embolic protection, and the primary endpoint was any stroke at 72 hours. Turned out that there was no difference in the primary endpoint, although there was a 0.8% significant reduction in disabling strokes in favor of the treatment arm with cerebral embolic protection. I think this is a tough one to digest for probably the company, but also for the believers and the non-believers, because the believers, I guess, will continue using these devices. For instance, I think we are still believers, and I would still want to protect my patients, because there is no doubt that you will capture debris in all the patients when you're doing a TAVI procedure. That said, patient centers and physicians who are more critical will say, well, this was just a negative trial. They missed the primary endpoint, so that won't change a lot of the practices. So I don't see that there will be a lot of increased adoption of this technology. And I guess we'll have to wait for the 7,000 patient PROTECT TAVR in the UK that is still ongoing. They are about halfway, and that obviously will make or break cerebral embolic protection in TAVI. What do you think, Joost?
Well, I have to say, I think I was surprised by the fact, not surprised. I mean, what I found striking was the safety of the device, virtually zero complications. Yeah. Procedure success, 99%. So the device actually is also in a broader perspective, 3,000 patients, really easy to use. The efficacy, there is a clear trend, and we already anticipated that you would need a lot of patients to prove significance. With these figures, you would need 30,000 patients. To me, at the end, it will come down to the price we are willing to pay to avoid stroke, which is a relevant adverse effect following TAVI, but also relatively rare one. I don't know. I think it will be difficult to convince a larger community. It will be difficult to justify a use in all patients. And I think that is something we need to learn from future sub-analysis to see if there are any particular categories of patients that might perhaps have a greater benefit.
Well, to put in perspective, the number needed to treat to prevent one stroke event was 125 for a disabling stroke, and that's obviously a lot. And if you then take into consideration that the price is around 2,000 euros, well, do the math, then it's quite a costly investment to protect one disabling stroke. There is also what was not presented, and also you cannot find it in the New England paper, is that there was quite some patient selection going on. So most sites were in the United States. Turned out that the sites who were participating in the trial also had a parallel use of cerebral embolic protection. So they were, or they could have selected patients who were more like less risky, because the patients who the physicians deemed really at high risk, they would not want to randomize those patients and just treat with a cerebral embolic protection device. So the rumor goes that the patient selection in the UK is less significant, that approximately 50% of all the patients are being treated within the study. So let's see what happens, but this will take definitely another 3 years, I think.
Yeah.
All right.
Alrighty.
The Clasp 2D trial, that was another interesting study. It's a smaller trial. It turned out that only 180 patients were randomized 2-to-1 to TEER with either Pascal or the conventional mitral clip, if you will. Patients had a degenerative mitral regurgitation and were deemed inoperable or at very high operative risk. As expected in our preview, we predicted that there would be a similar safety profile and also a similar efficacy. Turned out to be the case. However, patients in the Pascal cohort had more sustained reductions to MR less than 1 or 0. So whether that is a play of chance or not, that requires more data and more patients, obviously. And also we have to take into account that both devices, both the Pascal but also the MitraClip platform, were early generation devices. So I do feel that the good news from that study is that we have no longer just one option for TEER. There are now 2 solid options for TEER, at least in degenerative MR, and we'll have to wait for Clasp 2F, the functional MR subset of the patients, to also have a better idea about the functional MR.
Absolutely. Cardiogenic shock and TEER.
Yeah, so we are looking into expanding indications for TEER, and one of the indications could be cardiogenic shock. And this is a very tricky set of patients because we all know that mortality for these patients is very high. It's up to 50% at 6 months. Right. And now there was a presentation as a late breaker on more than 3,000 patients, almost 4,000 patients from the TVT Registry who were treated with a transcatheter edge-to-edge repair in the context of cardiogenic shock that was defined as the patient was in use of inotropics or there was a mechanical circulatory support device in situ. Mm-hmm. As expected, device success was very high. It was 84%. And in those patients, device success was defined as an MR reduction with at least 2 grades. And the device success also improved survival at 1 year. That said, the comparator was patients where there was no device success. So obviously that is a little bit of an awkward comparison. I think it's already intuitive that if you have a successful procedure, that patients probably will do better as compared to whether the patients had a non-successful procedure. We do not know what would have happened if they wouldn't have embarked in a procedure at all. So interestingly also, there was no significant or useful interaction. So the effect was seen in patients on inotropics, in patients treated with mechanical circulatory support, low EF, high EF, and also functional or degenerative MR did not affect the outcome. Wow. I think the main message for me is that in very selected patients, TEER can be a treatment option. And we are, from our own experience and previous studies, we can already learn which patients might be good candidates for TEER. For instance, an acute flail or a post-MI severe mitral regurgitation, those are patients that probably are relevant candidates, provided that you don't wait too long, because if the atria start to enlarge, then it becomes a totally different story. Yeah.
To me, an innovative design, and you actually just enlightened me, I thought this was a comparison of early TEER versus no TEER. But that was not the case, because that would have resulted in significant selection bias. In this case, you selected the same cohort of patients, all patients in whom you at least attempted to do it. And yet the results were it was a 16% reduction in mortality, numerically. I'm typically very cautious with trials like this in terms of scientific validity, but I think it's conceptually interesting.
But there is another context where they did the same thing, and that's in the CTO arena. There's multiple registries where they compared patients who embarked in a CTO, and they demonstrated that patients who ended up with a successful CTO did better down the stretch than patients with a failed CTO. But I don't know what the relevance is, but I think the good news is from time to time you can do a TEER in the context of cardiogenic shock.
Yeah.
Another niche indication was post-infarct ventricular septal defects. An interesting study from the UK where they included 362 patients, quite a large number of patients who were treated for a post-MI ventricular septal defect. And the patients were on average 2 days with a late presentation after STEMI when the diagnosis was made, and they were treated on average 9 days after the index event. The majority of the patients, 230 patients, underwent surgical repair. Transcatheter repair with a VSD occluder was applied in 131 patients. The in-hospital mortality was quite high. It was 55% for the patients in the transcatheter arm and 44% for surgery. And that tells you that, you know, a VSR in the context of a late presentation of a STEMI, that's an ominous sign. The patients will do poorly. And then we're still talking about a selection bias because a lot of the patients with VSRs who were not considered for treatment were not enrolled, not included in the analysis. Patients in the transcatheter arm were older, mean age of 72 versus 67, and post-discharge, and I think this is important, there was no difference in outcome between the two treatment arms. In-hospital mortality seemed numerically higher with the transcatheter treatment, but again, I think that had to do with patient selection. The worst patients got a catheter-based treatment, and patients where the surgeon still thought it was there was something to gain, then they were brought to the OR. So. Yeah, anyway, so I think on a case by case, this is again something that you need to decide when a patient is admitted with a late presentation of MI.
Absolutely. More on closure devices?
Closure devices, but this time LAA closures. We have the 3-year outcomes from the Amulet IDE study. This was a large randomized controlled trial comparing almost 2,000 patients with closure, LAA closure with the Amulet device or the Watchman device. We already knew that at 1 year there was no difference between the two device strategies, although LAA occlusion at 45 days was higher, was more complete, if you will, with the Amulet device. At 3 years, as expected, we did not see any difference in safety or effectiveness between the two treatment strategies, although patients in the Watchman arm had more often residual leaks and also thrombus on the device, and that resulted in more patients in the Watchman arm on oral anticoagulant therapy. And obviously, the main purpose of LAA closure is to get people off oral anticoagulant drugs. I think this is an interesting observation. We're still talking again about an early generation Watchman device as compared to the first generation Amulet. I wouldn't make too much fuss about that observation. I think here also the good news is you have multiple devices at your disposal when you want to close the LAA, and probably it is more anatomy and patient tailored selection of the devices.
Likely, and I would be very cautious to draw any firm conclusions from these subgroup analysis, so to say. Scope. Yeah,
Scope 1 at 3 years. I thought this was an interesting study. Just to bring it back to your minds, Scope 1 was a comparison, a randomized controlled study comparing the Accurate Neo, a first generation Accurate Neo with the SAPIEN 3 valve platform for patients with symptomatic severe aortic stenosis. At 30 days, turned out that Accurate Neo was inferior to the SAPIEN 3 based on a composite primary endpoint, and that was driven by more PVL and more acute kidney injury. At 3 years, no difference in the primary endpoint, so no functional status was the same between the two treatment arms, but also mortality was the same. But there was a clear trend towards more rehospitalizations and also more new onset atrial fibrillation in the SAPIEN 3 arm. And that is intriguing because we know that Accurate Neo had more paravalvular leaks, but also had better hemodynamic valve performance. So the question here is, okay, but down the stretch, does this hemodynamic valve performance that seems to be better, and basically the flip side is therefore more patient prosthesis mismatch with SAPIEN, does that come back and haunt the patients down the stretch? It is an hypothesis, it is a speculation, but the good news is that patients can be treated well with an accurate neo, and now obviously we have the accurate neo 2. Yeah. So the issue of paravalvular leaks has basically been resolved with this new iteration.
Alrighty.
Sunday we switch gears. Sunday we switch gears.
Yes. So Sunday started with a lot of focus on renal innovation by AJ Curtin, who presented the primary endpoint of the RADIANCE 2 trial, which was a randomized double-blind sham-controlled trial designed to demonstrate the efficacy and safety of the Paradise ultrasound renal innovation device in patients with mild to moderate hypertension who were taken off drugs. So, in brief, 224 patients that were randomized in a 2-to-1 fashion to either ultrasound innovation versus sham, and were followed for a primary endpoint of reduction in daytime systolic ambulatory blood pressure at 2 months. What the trial demonstrated were results that were very much in line with SOLO, so a 6.3 millimeter delta in systolic daytime ABPM. Whereas home blood pressure appeared to decrease by 7.6 millimeters of mercury in the RDN versus sham cohort. In a fact that appeared to be very consistent throughout the day, so a 24-hour always-on effect of RDN as we have been tended to see in the past couple of trials. They also presented some data on the percentage of patients being controlled, so just after the RDN, so no drugs, that appeared to be almost 20% in the RDN group versus 5% in the sham group. So all in all, very reassuring findings on the safety and efficacy of RDN. This trial was actually the first that was individually powered for either safety and efficacy. And again, as mentioned, so positive results, however, also results that should be put into perspective to the patient population studied. Low-risk patients, low cardiovascular risk, mild to moderate hypertension, off drugs, but yet I think promising and I think an important step forward into the discussions with guideline committees and reimbursement agencies.
But it's important what you say, and this is really a selected set of patients with hypertension, right? It's not every patient with hypertension. And also, this was a follow-up at 6 months, so
2 months.
Or 2 months.
2 months only.
So there you go. So basically, what you want to know to know and to learn whether this becomes a relevant treatment strategy is what is it? Is it durable? Is the effect durable of this innovation? And then there was obviously HTN3 long term.
HTN3 was probably presented indeed as well. So HTN3, you'll recall years ago, randomized trial, first large randomized controlled trial comparing radio frequency RDN with the SYMPLICITY Flex device versus sham controlled setting, primary endpoint at 6 months that appeared to be completely negative. So safety was confirmed. However, the trial missed its primary endpoint with a 2 millimeter difference in ABPM. But now the results at up to 3 years were presented, and that was quite interesting because we knew that the patients were unblinded at 6 months. Patients had the opportunity to cross over to a treatment arm. Changes were applied in drug therapy. Compliance was not measured. So all in all, a lot of confounders that we knew that would be the case. But despite these confounders, the authors were able to demonstrate that the drug burden over this period of time remained completely identical in the sham group, whereas in the RDN arm, drug burden actually significantly decreased. Despite that, the ABPM between 6 and 36 months remained completely identical in the sham group, whereas in the treatment arm, the RDN group, the effect of RDN actually appeared to increase over time by a delta of 8 at 1 year to 13 at 2 years to 17 millimeters additional reduction at 3 years, a finding that was almost too good to be true. Was questioned by some, and then I can say two things. One, these findings are exactly in line with what we've observed in Erasmus. If we follow their own cohort up to 4 years, we also identified less drugs, increasing effect. But Conversely, we also have to admit that, I mean, these data were based on 119 ABPMs out of 535 patients, so 20%. There was a lot of statistical tweaking into the results, with a last observation carried forward at 6 months of the ABPM value for patients that had the crossover. There was no drug testing, and so on and so on. So I think we have to be careful, but at least these results demonstrate the safety, I would say, of the technology, and potentially may add to the understanding of the durability of the findings in a setting that is very difficult to adjudicate on the long run, right? There has not been a single drug trial on antihypertensive drugs with an endpoint beyond 2 months. So it's also something that, I mean, should be put into perspective to the type of technology and what is realistic in terms of what we can study.
So just from my understanding, so only 20% of the patients who were enrolled in the study had 3 years follow-up?
Had ABPM.
Okay.
Office and home blood pressure measurements showed a identical trend and were available in more patients. But I just for now focused on the ABPM since I think that at least comprises the most... the strongest amount of evidence. Finally, on RDN, there were data on pulmonary artery denervation, as mentioned, the PADN-CFDA trial. So it's a mouthful. I don't even know. I couldn't find what the abbreviation stands for. But at least PADN is pulmonary artery denervation performed with a, let's say, modified EP catheter.
And CFDA is the FDA of China. But okay.
I could have known. Oh my gosh, that's why we do this together. So Chen presented 128 patients randomized 1-to-1 to either denervation versus sham. The trial looked at a delta in 6-minute walk test difference at 6 months, which actually significantly improved in the denervation arm as compared to the sham group. So positive effect. So with that, the trial met its primary endpoint. But also interesting, they did a lot of testing of the RV. So what they actually showed is a significant decrease in pro-BNP values, significant decrease in mean pop pressures, significant decrease in PVR. Conversely, also improvement in RV functional parameters, despite the fact that there was more addition of diuretics in the sham arm. So I think a promising treatment that is something that we may want to study further in a broader perspective in the future, even outside China.
But did they mention also changes in pulmonary pressures?
Mean pop significantly decreased.
But how much then?
I'm not exactly sure of the magnitude of the events, but it's significantly decreased.
But you know, all in all, this is an important option for those patients, because there is not a lot. There is not a lot. So if we could come with some kind of mechanical treatment for pulmonary hypertension, I think there's an unmet need.
All these patients were on phosphodiesterase inhibitors. So I mean, they were already on more standard of care therapy. So to me, interesting.
Universal.
Universal, yes. So
what is the ultrasound-guided access?
So in brief, a negative trial. So 600 and something patients randomized 1-to-1 to either ultrasound-guided access for patients that were admitted for a femoral coronary artery procedure, so PCI in most of the cases, versus standard femoral artery access. The trial was powered to design a superiority in terms of BARC bleeding to 305. Did not meet that endpoint. Finally, 12.9% bleeding in the ultrasound arm versus 16.1% in the control arm. So no P for significance. However, what was interesting, I think, is that the trend went in the right direction. The patients in the ultrasound-guided arm actually had faster access times. So ultrasound does not add to procedure time. I think that was an important finding. The likelihood of gaining an access in the first attempt was significantly higher in the ultrasound group, 85 versus 70%. Plus, what I found the most striking thing in this study is that there was an interaction with the use of closure devices. In patients in which there was a closure device used, there was a significant benefit in terms of bleeding in the ultrasound-guided group, whereas this effect was not seen in those who had no closure devices. Now you ask, how many closure devices? 50%. I was surprised.
Yeah, well, but you know, if you take this into our practice, we would struggle enrolling patients in this study because we hardly do femoral diagnostics or even femoral interventions these days. We typically rely on coronary interventions through a transradial approach. So I think the benefit of ultrasound will only emerge in large bore arteriotomies because there is so much more at stake. The bleeding events will be more and more impressive. So that's what we discussed up front in our preview. We were anticipating that this would end up being a negative study. So no surprises there.
All right, FLASH.
FLASH was an interesting study. It is a large prospective registry where patients with pulmonary embolisms were treated with the FlowTriever mechanical thrombectomy device. 800 patients were enrolled, so that is quite a high number, but only 8% were high-risk pulmonary embolism patients. So the overwhelming majority were at intermediate risk. And intermediate risk pulmonary embolism is not a guideline recommended therapy, mechanical thrombectomy. So they were exploring new indications, and this is very popular in the United States. But still, we have to be cautious with the extrapolation and in our everyday practice. So I think the good news is it's a very safe treatment and it works. So you will see a significant drop in your pulmonary artery pressures, in your heart frequency. The patients will have less oxygen need. I'm a believer also in patients with intermediate to high risk pulmonary embolisms. But on the other hand, we do need randomized studies for this particular indication or in this particular indication. So for me, there's a clear path. Green lights, all the lights on green, to use this technology to treat patients with high-risk pulmonary embolisms. In the intermediate risk to high-risk patient population with pulmonary embolisms, we probably need a randomized control trial. But the good news again, low bleeding rates and low mortalities. Mortality rate of 0.8%, that's nothing.
That is promising.
And also the bleeding rate of less than 2%.
Yeah. So for Sunday.
So let's switch to the coronaries because we haven't spoken about coronaries.
No. Well, on Monday, Young-Min An, our friend from Korea, kicked off with presenting the 10-year result of the BEST trial. So you recall randomized controlled trial comparing PCI with contemporary DES, Zynes in this case versus CABG for patients with multivessel disease. Recall BEST was the trial that aimed to enroll almost 1,800 patients, but then was stopped prematurely at about 880 patients. Right. I mention this because also the 10-year results that he presented were based on a descriptive basis only, so no formal non-inferiority testing was performed. Primary endpoint of the trial was death, MI, stroke. At 10 years, the numerical difference of the event rates in favor of CABG, but no statistically significance. Death, MI, stroke rates were looking at the event curves completely overlapping in both arms. However, TVR rates were significantly lower in the CABG arm as expected. Now, what I found interesting, so thus far no great surprises, but what I found interesting was the fact that in the previous trials, 10-year Syntax, Freedom, Fame, there was always a trend towards lower mortality rates in the CABG patients, but not in BEST. You would say, well, it's only 880 patients. Yes, that's correct. But what is interesting in BEST, 72% IVUS use. So the authors did a subgroup analysis looking at the results in the IVUS-guided treated PCI patients versus the not IVUS-guided treated patients. Event rates were double. So in the IVUS-guided PCI arm, identical event rates as compared to CABG, 22% in both arms. But in the non-IVUS-guided PCI treated patients, rates of death, MI, stroke, and TVR, 43%. So that was almost double. Interesting, of course, hypothesis generating, but I think again, additional reason to look out for the series of randomized controlled trials that will add to the body of evidence on superiority of IVUS-guided PCI.
Well, and it underscores our practice and what we are preaching almost every day, that in this day and age, PCI requires imaging, invasive imaging to optimize your results, and you will get better clinical data down the stretch. And I think the other reassuring thing, no difference in mortality at 10 years. So basically, And I feel comfortable with that. That okay, you may inform your patient. There's no difference in mortality, so your survival is identical with a less invasive PCI treatment as compared to the invasive CABG. But at the same time, you can expect more revascularizations. But okay, sometimes a touch-up here or there in a 10-year period, that's not unreasonable to me.
Yeah, I agree. Then,
Favorite 3.
Yes, more from China. In this case, the 2-year result of the Favorite 3 trial. So you know, this was the trial I was quite enthusiastic about very recently when it released its 1-year findings. So a trial looking at the superiority actually of a QFR guided treatment strategy for coronary artery disease of intermediate lesions versus a angio guided approach. The trial demonstrated at 1 year significantly lower event rates in the QFR guided arm, and now presented the 2-year findings of the trial. So we expected actually not that much difference at 2 years, and that appeared to be the case. So event curves remained more or less identically separated between 1 and 3 years. Although there was a slight catch-up, I have to say, in the events in the angio-guided arm at 1 year, which, as acknowledged by the authors, was added to the fact that there were some non-clinically driven revascs in this Chinese population with operators that apparently had a low threshold for calling patients back in at 1 year. I would say that here that would be quite rare. But in the trial that was apparently the case. And finally, lots of sub-analysis on reclassification and discordance. Perhaps too much for now, but I think overall reassuring findings on the potential benefit, if not superiority, of angio-guided FFR versus standard angiography-based PCI.
Yeah, and well, you know, the potential implications are significant. If also other trials like FAST-3 and others become positive and all point in the same direction, then this might be a transition from invasive hyperemic or non-hyperemic coronary physiology assessment to angio-derived coronary physiology assessment. So I think that from a patient perspective, but also from a procedural flow perspective, that would be a clear difference.
Yeah. Epic STEMI. So just to briefly highlight Epic STEMI, I like the concept. So addition of PCSK9 in the early phase after STEMI. So 100 patients randomized to high intensity statin post STEMI. Plus alirocumab 150 milligrams versus sham, looking at the potential of this PCSK9 inhibitor to reduce LDL at 6 weeks. This trial appeared to be highly positive, 22% more LDL reduction in the PCSK9 group as anticipated, safe strategy, and a significant greater proportion of patients being on target, even when adjudicated according to the most recent European targets and US of 1.4. Promising. Whether this will result in a better outcome is yet to be studied in a hopefully subsequent outcome trial.
Yeah, but I bet that would be a positive study. So you can only anticipate better outcomes. I think the downside of this therapy is obviously the cost.
Absolutely. Yeah.
Okay, and then the last two?
Yeah, the final two small studies that I would like to highlight together were the last trials, or one of the last trials presented on Monday, are COPS and EXIT-CALC. So 2 trials looking at the potential of calcium modification strategies in order to optimize stent expansion. So COPS was the Italian trial presented by Antonio Mangieri, who randomized 87 patients to either a Wolverine cutting balloon or a standard non-compliant based strategy. Cutting balloon, by the way, in this case with high pressure, whereas the IFU says you shoot low pressure. Looking at stent expansion finally in the IVUS assessment, no difference in final minimal stent area, 7.1 versus 6.5 square millimeters. Potential larger effect of the Wolverine balloon in lesions with calcium more than 270 degrees, but also numerically somewhat more device failure in the Wolverine arm, 7% versus 0%. Small study, hypothesis generating. I would also, with respect to this one, not put too firm conclusions. I don't know what you think.
Yeah, I'm not, as you know, and I think you are the same as I in that regard. We're not so super enthusiastic about cutting balloons or scoring balloons. Yeah, it's a niche product, I feel, and you come a long way with decent conventional lesion preparation. And the moment we see extensive calcium, there are other devices at our disposal these days. You have rotational or orbital atherectomy, and you have shockwave lithotripsy. So what about lithotripsy?
So a similar study, and that's why I highlighted both, because I think it's tremendously important to properly study these devices. I mean, there's a lot of fuss on the potential efficacy of these technologies, but there's actually very little randomized data supporting the superiority of cutting balloons, scoring balloons, but also lithoplasty. And in that perspective, I think the colleagues from Amsterdam should be congratulated, randomizing 40 patients to either IVL or conventional NC balloon lesion prepping in order to look at stent expansion. 40 patients, so a very small number, but these patients had to meet the entry criteria being a high calcium score based on the vaginal score, which is the one that we use, so based on length, arc, and thickness. But then reported no difference at all in stent expansion, 82% in the shockwave arm versus 84% in the conventional arm. Final minimal stent area 6.6 versus 6.2. Conversely, in the shockwave arm, more calcium fractures, less stent dissections, safe technology, no periprocedural complications actually in both arms. So down the line, I think a inconclusive study in a device that we've learned is effective in certain patients, specifically those in whom you with a non-compliant balloon do not manage to fracture the calcium, but perhaps also not a technology that should be used in everybody with severe calcification.
Yeah, I think, very small numbers, so we need to be very cautious with extrapolating the data. But that said, shockwave might be a niche product, right? If you really see particular phenotypes of calcium, it might have added value. But in another group of patients, it might not. Yeah. And this is also, focus of research in Erasmus. We're definitely looking into the patterns of lesion modification and also in differences in stent areas, minimal stent areas after lesion modification with these devices. So much more to come on that.
More to come.
But small numbers. Yeah.
Alrighty. So far, TCT 2022.
Yes, I think, again, good meeting. We were happy to be in Boston. And then we look forward to the AHA. And that is on the corner. It will happen, I think, in November. So stay tuned then for another preview and then a wrap-up of AHA. Thank you very much for being with us. Goodbye.
Thank you, and goodbye.